obviate in the future the need for ovarian stimulation, even for many patients, not for all, but for many patients. And so I'd like to start out with talking about ovary transplant, because that's where all of this knowledge came from, was from our experience with ovary transplant. What we do is freeze the ovary tissue. We started doing this in 1997 for young women with cancer who are about to be completely sterilized by their bone marrow transplant. Froze the tissue. As long as 20 or 23 years later, transplanted the tissue back. And by now they were 45 years old with a 20-year-old ovary. And lo and behold, 76% of them got pregnant, had healthy babies. And we now have 19 babies from these women who were sterilized by their cancer treatment up to 23 years ago. And it's from the tissue of those patients that we learned about how to make eggs from skin cells. So let me just start with 3 videos that will emotionally really grab you. This is the first one.
I think that there's never been any doubt in my mind that I wouldn't be cured of this. Once I found out, I just made up my mind, that's it. You just have to keep taking it one day at a time and just keep that positive attitude and know that I can do this. I'll get through it.
It's 8 o'clock in the morning, July 17th, 1997. We're at St. Luke's Hospital, and we're about to do the first case in the St. Louis area of ovarian tissue freezing.
Okay, well, I'm Dr. Silver, Sherman Silver, the Infertility Center of St. Louis, and we really have a treat right now. This is Jennifer, who at 24 years of age, I'm right on that, yes, right? Came down with a terrible case of leukemia. They thought she was going to die, but just to be safe, in case she lived, when she did, and was cured, we would freeze her ovarian tissue. So that was like 20 years ago. And this is the first case that we ever did, and we're the only ones right now really actively with a program in the whole United States. And it's been a long time, and we didn't know that we'd be able to transplant the tissue back, and we didn't know if we could culture the tissue. And here she is now. We had her on Facebook Live several months ago, and she was happily pregnant, and now look what we have. Now she's 44 years old, if I can reveal that, with a 24-year-old ovary, and a beautiful baby. What's her name again?
Madeline Grace.
Madeline Grace. Here's the second case. Dr. Sherman Silver, Infertility Center of St. Louis. And I'm here with the most amazing fertility story ever. This is Amy Tucker. I've known her since she was a little 19-year-old girl who was facing death with Hodgkin's disease, a terribly difficult case. And she's got 2 children from her frozen ovary that we froze before she underwent her chemo and bone marrow transplant that sterilized her, and she's now pregnant with twins. She's going to wind up having 4 children from this ovary we froze before she had this life-threatening cancer and was treated for it. Here's the next one. This will be the last example.
The fact that I couldn't have children really scared and frightened me.
2 years ago, at the age of 21, Melissa was diagnosed with Hodgkin's lymphoma. She was told her treatment would include very high doses of chemotherapy.
I thought, I'm young, I can do it. The odds are looking really great for me. Hodgkin's lymphoma, very curable. And then I really started looking into my papers and my books that you get, and I came across fertility. And I burst into tears. I don't have a biological clock anymore. He took it away from me. So when I'm ready to have kids, it's not going to be a problem.
Well, Melissa, this is a fantastic moment for all of us.
It is.
I mean, when are you going to have the baby?
We are scheduled for a week from yesterday, so 6 more days.
6 more days, and you look really ripe.
I am very ripe, yes.
So I thought those examples where we were lucky enough to get some video would really grab everyone to realize how dramatic this is, that this procedure that was begun by Roger Gosden in sheep revolutionized the whole cancer world, and that we can actually get women pregnant with ovary tissue that was frozen before they were sterilized by the cancer treatment. But out of this also comes our understanding of ovarian longevity, how you can make your ovary last longer, how you can maybe last longer, in vitro maturation, where we can actually get eggs right out of the ovary without even having to do a transplant, and how we can be making eggs just from a simple skin biopsy. This is not science fiction, and this is not flim-flam stuff. I mean, you hear about platelet-rich plasma, and you hear about ovarian stem cells, and you hear about all, DHEA and growth hormone, all these things that haven't been very successful. But this really works and is really scientifically sound. Now, this is me with Katsuhiko Hayashi. He is the genius who first in mice were able to make healthy baby mice from skin biopsies, skin cells from the mother mouse who had no ovary. And we're working together with him in a big collaboration between him and Kyushu and Amanda Clark at UCLA Stem Cell Center, with Kyle Orr at University of Pittsburgh. And you can see there on there with my science assistants, Sierra Goldsmith, and with Hong Ping, who is the incredible person that has been helping encourage us to develop this project, to be able to do in vitro maturation and to create healthy eggs in the human, not just the mouse, from skin cells. So first, I'll give you a summary of the whole goal of what we call the CHOSE project. Primary goal from this international collaboration is to make pluripotent stem cells from skin cells, and from them to create functional eggs. So Hayashi's original work on mice demonstrated creation of functional oocytes resulting in healthy babies produced from mouse PGCs, pluripotent stem cells that were made into mouse PGC-like cells, aggregated with fetal ovarian somatic cells, granulosa cells, and then eventually made into eggs that resulted in healthy baby mice. But now you need to have fetal granulosa cells to pull this off. So PGC-like cells are precursors of sperm and egg. They can be derived, and the next step is to make mature gametes. However, there's one obstacle. We need fetal gonadal somatic cells, or granulosa, and fetal granulosa cells to recreate what actually happens in the fetus that I talked about in the talk on Journey of the Sperm. And one possible way to solve this obstacle is to differentiate iPS cells in a different culture system, not to PGCs, but to granulosa cells. So we have two systems, a system with PGCs and a system with granulosa cells, all derived from skin cells. Mix them together and we get normal oocytes. So based on our knowledge of in vitro gametogenesis in the mice, we only need fetal gonadal granulosa cells, and there have been attempts to incubate human PGCs in mouse fetal granulosa cells, but it doesn't work. It has to be species specific. And we've now discovered all of the growth factors created by mouse fetal granulosa cells, so that fetal granulosa cells are no longer needed in the mouse system to make competent oocytes in babies. We are now working on converting these human PGCs derived from skin biopsy in our menopausal patients into functional oocytes by differentiating iPS cells in a different system into fetal granulosa cells. So that's what we're doing. Now, let me go to first the ovary transplant and what we've learned from the ovary transplant by applying this knowledge of in vitro gametogenesis. First, a summary of the results. It's pretty significant. We have 30 healthy babies so far from ovary transplant, and 11 came from fresh ovary transplants, but the more dramatic 19 babies came from ovary tissue frozen before the woman had treatment for her cancer, and they were frozen either by slow freeze originally or by vitrification. Either way worked just as well, and we have healthy babies from that. And if you look at this busy slide, you can see the summary on the bottom. Of 17 cases of transplant, we have 19 babies, 13 pregnant with delivery, 76%. 76% successful delivered pregnancy rate, 12 females, 7 males, 6 by vitrification, and 11 by slow freeze. And you can see anything from ovarian failure to Hodgkin's to brain cancer to synovial sarcoma to leukemia to large cell lymphoma, all kinds of cancers. And if you look at a different slide, you can see the age at the transplantation and the age at the freeze. And one of the reasons this is so successful is that these are young cancer patients. If you're freezing ovary tissue at age 40 with a breast cancer patient, your results aren't going to be so good. But we're freezing young patients' ovary tissue before they're treated for their Hodgkin's or their leukemia, which are the most common diseases they suffer from. And it used to be thought that you can't treat, you have to use only slow freeze, but we found with an easier method of freezing the ovary tissue with vitrification, the cells are preserved just as well. Now, frozen ovary transplant for cancer patients, how does it really work? Well, the primordial follicles, these are the resting follicles, are all located in the cortex of the ovary, and they develop towards the softer center. And now we understand why that is, because they're arrested in that dense tissue of the cortex, and they gradually develop 1,000 every month, actually, over 200,000 over a lifetime of an ovary, maybe ovulating one follicle every month, but 1,000 eggs every month are lost because that's the rate at which they're retrieved from their arrested primordial phase toward the center. So all we really need to do to save most of the eggs is to preserve that outer cortex. So here we are, an ovary tissue has been removed, and we're going to shave off the outer cortex. We're going to vitrify it, and you can see the fresh human tissue pre-freeze with those follicles looks no different than the tissue post-vitrification, post-freeze. Now, once we thaw that tissue that's been frozen for up to 20 years, we quilt those pieces of tissue together under the microscope with nylon interrupted sutures. And you can see that the outside of the cortex is now one quilted piece, and we're going to transplant that tissue now onto the dead ovary medulla in a position where the fallopian tube can easily reach it when it ovulates. So we don't do IVF. We just let the women ovulate naturally. And all these pregnancies I told you about with 19 babies and 76% success rate are natural pregnancies, not IVF pregnancies. Here's a dramatic case of a woman who had an ovary transplant, and she's 46 years old now with her 3 children, all derived from the ovary transplant. Here's a case of the Amy Tucker that you saw earlier with her husband and her 4 babies. And she was going to die of severe Hodgkin's disease when she was just 19 years old when I first froze her ovary tissue. And here she is quite healthy. And interestingly, she is an oncology nurse. She's an oncology nurse at Washington University. And she has 4 healthy kids, despite the fact they thought she was going to die when she was 19. And here's a summary of leukemia cases. I think this is very interesting because it has been said that patients with leukemia may have cancer cells in their ovarian cortex and that you shouldn't transplant it back. But we found out, based on the work of Anderson in Denmark, that we owe a huge amount we owe everything to Denmark, to Anderson in Denmark. And what we find is that the ovarian cortex is not a hospitable place for cancer cells. And after the initial chemotherapy, there's no viable cancer cells in the cortex. And so as long as we froze the tissue after the initial chemotherapy and before the sterilizing bone marrow transplant, that tissue is safe to transplant back. Now, just look at this summary. We already have 6 babies from leukemia patients, and we were the first ones to have babies from leukemia patients. We were slow to publish because we wanted to wait to get a series, but we were the first ones. And look at, they're all still functioning. That first one, she had it frozen when she was 18 years old. We transplanted it back when she was 25. and still at 93 months, it's still functioning. The next one is still functioning at 87 months, and another one is still functioning at 65 months. So these ovary tissue pieces last a long, long time, and they can have many babies from it. Now, this is a picture to demonstrate why the ovarian cortex is just not a hospitable place for metastasis. It's fibrous tissue. It's no different than the tunica albuginea of the testes in the male. And we know that tissue is very inhospitable to cancer cells. And particularly after the initial chemotherapy, cancer cells are wiped out. But the primordial follicles are more resistant because they're like spermatogenic stem cells in the fact that they don't develop at all. They don't grow at all. So they're the last tissues to be wiped out. We transplant back in 4.5 months. Later, we have a functioning ovary. So this is our first leukemia patient. That was when she was 24 years old. There she is with her husband at 41 years. And there she is. You saw her in that video before with her baby with 24-year-old tissue. And there is our other leukemia patient whose tissue was frozen 15 years early, now has 5 babies. You can see her, she's shorter than even I, and I'm very short. And you can see her growth was stunted by her bone marrow transplant, but it doesn't matter because she is fertile now. There she is with her first baby, and she has 5 babies now from the transplant. So we use this knowledge that we gained to do in vitro maturation because many people are afraid to transplant the ovary tissue back for fear of transplanting back cancer cells. It hasn't happened yet, but there would be an advantage to just being able to get eggs and not just transplant ovarian tissue. Now, if you stimulate the patient for IVF to get eggs, she'll have to go through 3 cycles to have any assurance and to get many eggs. And that stimulation is going to actually delay her cancer treatment. What we found is it's a very, very simple recipe for IVM. It's very, very easy. It's not difficult like we thought it would be for 30 years. And let's explain, because that's an outrageous statement. There are doctors that have done research on this for years that'll be offended by it. But let me explain why it's so easy to use ordinary media, nothing special, and get good IVM culture. And it's based on the work by Hayashi and by our CHOSE project, in vitro gametogenesis. This is what we do. First, we have the ovary removed, and we're going to dissect that ovary in order to just freeze the ovarian cortex like we normally would so we can transplant it back later in life. And as we freeze that cortex, as we dissect that cortex out, all of these early follicles, tiny, you don't even see them on an ultrasound, will be releasing oocytes into the culture media. That's where the GV oocytes are. So this is the piece of cortex that's been cleaned off, and we're going to freeze that for ovarian tissue transplantation later in life. And you can see we're putting it in pieces so that it can be freezable. And then they're ready in a Petri dish to be frozen, and we vitrify. There they are in the Petri dish. And there we are going to another step further. We're picking up the individual eggs in the media that are just lost in the spent media after we did that dissection. And you can see that although all we care about in the dissection are the primordial follicles in the ovary cortex, you can see in this histology, there are developing immature eggs farther internally. And we're releasing all of them into the media, and let's see what we can do with them. Can we take this immature GV, and if it's singled out on its own in simple media, can we make it a mature M2 oocyte just like you would get for IVF? So here's what it looks like initially. When you look at it in the media, you see a compact group of granulosa cells around the egg. And then within 24 to 48 hours, we look at it and you see a normal metaphase 2 oocyte. Not all of them. Here you can see 3 are metaphase 2 oocytes. 2 of them never matured. Here you can see 1 degenerated, 1 did not mature, but 3 of them did mature. And if we look at the summary of IVM, you can see we used a variety of media. Quinn's cleavage media, just ordinary IVF media, Metacult IVM media, Sage IVM media, Quinn's cleavage media, we used a variety of media. It didn't make any difference. We used a variety of concentrations of HCG, as a matter of fact. And with relatively low concentrations of HCG, it didn't really matter very much. We got a high percentage of oocytes that became M2. You can see the IVM rate is sometimes low when we had a lot of HCG in the specimen, and sometimes extremely high when we had a minimum of HCG in the specimen. And so the average IVM rate was 35%, and then we vitrified those M2 oocytes. And that's as many eggs as you'll normally get from ovarian stimulation of these patients. The average number of ovary pieces was 17, so we have two ways now of preserving their fertility. One is the frozen ovary tissue, but we also have oocytes that are mature. And take a look at this related to the patient's age. The IVM rate was obviously higher with a lower age, but none of them were that old. And in one older patient, 41 years of age, we actually got 67% IVM rate. So you can get very high rates of in vitro maturation. And you can see, again, the variety of culture media. You don't need specific IVM culture media. And this is a more busy summary that shows everything about the patients, which is hard to talk about in a specific talk. But at any rate, these were all between 24 and 48 hours of exposure to HCG in varying concentrations, resulting in the metaphase 2 eggs. Now, the Anderson group in Denmark studied this scientifically much better than we did. And they did next generation sequencing of 53 M2 oocytes and their first polar bodies derived from this M2 method. And by the way, this IVM method is we're just using their method. And the only difference is that we're using a variety of media based on Hayashi's IVG methods. 64% of these oocytes were euploid. That's completely normal. I mean, you're not going to get any more percent of oocytes that are euploid if you do standard simulation and egg retrieval. And the M2 rate was 1 in 3, resulting in a total number of oocytes that was actually similar to what you'd obtain from ovarian stimulation. So there are many. Why does it work? Well, there are many GVs inside the media that have adequate time of exposure to in vivo to FSH. That's because there's so many of them, 1,000 per month, that were recruited from primordial follicles 4 months earlier. It is so easy to collect many GVs from the tiny follicles by having the ovary in hand rather than using a needle. And 30% of GVs approximately have already been made meiotically competent from in vivo exposure to FSH for 10 to 14 days. That is, they've already gone through their IVG, as Hayashi would say. So you do not need ovarian stimulation for oocyte maturity. FSH has already created GVs with meiotic competence. You do not even need the normal ovulatory cycle for meiotic competence of GVs because you can use HCG in vitro. All that you need ovarian stimulation for, or the ovulatory hormonal cycle for, is for follicle enlargement and either monoovulation or for oocyte retrieval. It's just to get the egg out of the ovary. Otherwise, you don't need stimulation. Now, our rates really, as we looked at it, were very similar to everybody else who's done this. Hayashi had a IVM rate of 30% in mice. Seegers had 39% from Brussels. And by the way, they have a great program for this in Brussels. Klaus Anderson, with an equally great program in Denmark, had a 31%. And we had originally 32.3%, but now we're at 35%. So we all seem to have, no matter what our media that we're using, have the same percentage of in vitro maturation to M2, no matter what the media. So will these result in pregnancy? Well, there are people that preceded us with this, and they were pioneers, and they have very healthy pregnancies from in vitro matured oocytes after ovarectomy in a cancer patient. This is Prasad et al. From 2014. Seegers, 2015, who I mentioned, they have Michel DeVos, they have a spectacular program for IVM in Brussels, and they reported the first baby in 2015 from these in vitro matured oocytes. And even from Louisville, not far from us, we have, again, a healthy baby just from ovarian tissue IVM. And then Seegers in 2020 reported the first live birth with vitrification of these oocytes derived from IVM. So we have every reason to believe, based on Anderson's next generation sequencing and the euploidy, and from the live healthy babies from these other groups, that these oocytes will be healthy, functional oocytes. Why does it not require special media? And does HCG concentration specificity really matter? Well, again, I'll call to the work of the X chromosome, Dr. Hayashi and myself, and I only have a few more minutes to go into this, but I'd like to go into it a little bit. Again, it all begins here with the epiblast, which I've talked about in Journey of the Sperm. And in vivo, oocytes 4.5 months after recruitment have completed IVD and IVG, just like in vitro, but this was in vivo. So they're all ready for IVM. There is a constantly changing daily dynamic. Oocytes that were recruited less than 4.5 months after recruitment are going through either early IVD or later IVG. In vivo, once the oocytes have completed IVG, they are meiotically competent and ready for HCG or the LH surge. This is a constant daily process. At any time, a certain number of oocytes in the in vivo ovary have completed IVG and are ready for IVM. The GVs that just became gonadotropin sensitive are the ones we get with ovarian stimulation. New GVs are appearing daily after finishing IVD. Mature GVs that have finished IVG and are not ovulated or not matured by IVM or fertilized will die. So in an ovulatory cycle where one lead follicle becomes dominant, the non-dominant follicles still are going through IVG and attain meiotic competence. But as they get older, they are less capable. So we do not need ovarian stimulation for oocyte maturity. In vivo FSH has already created GVs with meiotic competence. We do not even need normal ovulatory cycle for meiotic competence of GVs. We only need ovarian stimulation or the ovulatory hormonal cycle for follicle enlargement and either monoovulation or for oocyte retrieval. Now, what is it regulates tissue pressure and ovarian longevity, and in fact, our longevity in general? And I gave you a clue. It is tissue pressure or myotonic tension, and I'll explain to you what's that doing. I have to go quickly because I don't have much time. I first speculated this when I saw that after our ovary transplants, when the FSH came down to normal 4.5 months after surgery, the AMH went sky high and then went down lower because there was a massive over-recruitment. And I speculated that was due to release of tissue pressure. This has been verified by Shea and Woodruff, but now in a more spectacular way by Nagamatsu, who is a young doctor in the lab with Dr. Hayashi. And what he found is phenomenal, and it can apply to everything in your life, really. It'll actually encourage you to exercise more. Mechanical stress is accompanied by nuclear rotation, and that's involved in the dormant states of the mouse. The histological analysis revealed oocytes were compressed by surrounding granulosa cells with extracellular matrix. This environmental stage is functionally crucial as oocytes became active upon loosening the structure, and the dormancy was restored by additional compression with exogenous pressure. So you can see that dormant follicles, the nuclei rotate, recruited follicles, the nuclei are static. So let's just take a look at this. You can see the nuclei in the cortex are rotating, so they are dormant and they are arrested and they are not in any danger. They're like stem cells. But the nuclei that are recruited and are developing and therefore in danger have no rotation of the. You can see again, decreased pressure stops rotation and increased pressure starts rotation. So that's been proved in a high pressure culture system. Pressure affects the primordial follicle activation. And so what is it that determines ovarian longevity? It's tissue pressure. Now, I don't have much time, so I'll make a summary. And that is that when women undergo pregnancy, their intra-abdominal pressure increases. Their AMH stops decreasing as it normally does throughout life during their whole pregnancy and for 3 months afterwards. And then the AMH begins to start going down again. And that's because she stops recruiting primordial follicles because of the increased pressure in her abdomen.
And that's why women who have 15 babies will often have more babies, because being pregnant sort of puts the ovary to sleep, as Professor Liang from China once said in her expression. But also this is important in general, because myotonic stress causes nuclear rotation, which will cause slower development of any egg or stem cell. So I don't know if this is true, it's just a speculation, but I would guess that exercise and myotonic stress would be a good way of improving your longevity. Here is the tissue stroma difference in just a segment of ovarian cortex. And you see it's that differential tissue pressure that regulates the recruitment of follicles. And you can see the AMH normally goes down throughout life, but when you're pregnant, it stops going down during that time. So the mechanism of pressure-induced ovarian longevity is nuclear rotation and nuclear migration of FOX3. So we've tried to talk a little bit about the science based on the original ovary transplants. And we think we're heading towards an era where not only will we be able to transplant frozen ovary tissue, but also just simply retrieve good mature eggs for IVF that didn't require ovarian stimulation. And we may even have a way of increasing ovarian longevity and maybe even our own personal longevity. Thank you very much for allowing me to go on like this. I appreciate your attention.